I am incredibly grateful to be here today and incredibly grateful to Dr. Nguyen for making this possible, because without her collaboration and support, this really wouldn't be. And so I am going to hopefully be able to help you today kind of learn to see a patient space that I see very clearly, but I think has kind of eluded us for a long time in medicine. And so, kind of how do I approach seeing these things that aren't super obvious? And I think that part of it comes from actually remaining curious about things and embracing the immense complexity of biology, and also recognizing the limitations of our tests and sort of the diagnoses that we give patients, particularly clinical diagnoses, where we're not actually basing our diagnosis on molecular mechanisms, but kind of like clinical phenotypes, right? There's limitations when we do things like that. And then also our current knowledge, right? It is expanding every day. And so we have to recognize that there are things that we currently don't know. We also have to understand that biological systems do not actually recognize our medical specialties, right? We must approach patients as biologically complex integrated systems. And I think the other important piece is actually believing our patients. So even if they're having an experience that we can't currently understand with our framework that we have, we must believe them and kind of, organize that into our thoughts about their case. And so what does a neuroimmune access disorder patient that I see look like when they're on the medicine wards? Because they're here all the time. They tend to stay for long periods of time. So I kind of put this schematic together to kind of help you maybe kind of recognize them. And so they come in oftentimes with a lot of different diagnoses, right? And so these can include things that may seem a little bit disparate, right? They can have some autoimmune disease, some maybe like autonomic nervous system features, maybe some connective tissue diagnoses, but it's not really clear. So they have a lot of diagnoses. And then, the other point that I want to make is that these aren't rare conditions, right? So we have autonomic disorders. And so POTS is one of them that we commonly see in our patients, or postural orthostatic tachycardia syndrome. It's not the only autonomic nervous system disorder. We just have a particular way to measure it and diagnose it. We've met clinical criteria. We actually don't know the mechanism of that condition. That impacts about 1 in 60 people. And that's increased dramatically since COVID, right? Because a lot of people get into this space after an immune activating event, such as an infection. And then if we think about like heritable disorders of connective tissue or extracellular matrix disorders, there's over 300 described, and this impacts about 1 in 3,000 people. So again, we're seeing this more frequently than we recognize. And then an area I'm particularly interested in is actually inborn errors of immunity. And so there's over 500 currently described, and every year that number increases. And so this is impacting about 1 in 1,200 people. And so again, these are not rare diseases. They're just misdiagnosed or underdiagnosed. And it's not to dismiss rare diseases, because rare diseases collectively are not rare. But in this situation, I'm going to ask, when you hear hoof beats, I want you to think horses, not zebras. And so I'm going to spend some time today talking about a specific clinical cohort, because they're on the wards all the time. They come frequently, they stay very long periods of time. It feels like we make very little progress in their care. And so this is this intestinal insufficiency, intestinal failure cohort. And this is not a benign condition. This is a life-threatening condition and a life-limiting condition. And so this is what this looks like, right? These are the patients. And so you can see Samantha on the left. She was my first patient in this space many years ago. She entered this space after an RSV infection. She quickly developed autoimmune diabetes, then autonomic dysfunction, and then intestinal insufficiency, and then intestinal failure. And she struggled until she passed at 26. Some of these faces you may recognize. They've been here, they've been hospitalized for long periods of time, they come and go. This is the way they want you to see them. This is who they want to be. But when they're here in the hospital, that's not who they can be. They're really struggling. And so just to sort of define intestinal insufficiency the way I see it, they're often unable to achieve a goal enteral feeding rate. And that sounds so benign, right? But we're kind of like pushing them, we're increasing the rate because we need to get them out of the hospital. We need to meet their nutritional goals, but they can't do it, right? They have a lot of symptomatology with it. And this can come from dysmotility, right? For sure. But actually I have a lot of patients who have really delayed transit times in the small intestine, and I can still feed them, right? So that's not the only piece, right? There's rate of transit, there's discoordination, there's intestinal barrier disruption that happens. Some of the clues we see that this may be contributing is you see a lot of bile return to the stomach, or it's that patient that has that J-arm extension from their PEG returning to their stomach frequently, and you're asking us to replace it, right? Like this is indicative that there's something bigger at play here. Then they have a lot of pain, right? But we don't know the source of the pain. And then you have the progression to intestinal failure. So this is when they become TPN dependent. They're unable to even receive medications in their J-arm, whether it's a direct or part of a PEG-J. And everything infused through that J-arm is causing a significant amount of pain. Even a few cc's of normal saline is not tolerated. And so they also will have a significant amount of nausea and often vomiting. The other thing is they start to get progressive fasting hypoglycemia. And so over time, their TPN is actually running 24 hours a day. They can't be off of it. So there's really significant physiological disruptions at this point. And so now that we sort of know who we're talking about, and I imagine everyone here kind of has a patient or two throughout their career or training that they can kind of point to that maybe fits in this space. So what I'm going to try to do is frame these conditions sort of through this neuroimmune axis lens for which I see them. And so this is kind of sort of the way I think of it. It's sort of like visualizing this at multiple scales. And so at the systems level, right, we have the nervous system, the immune system, and the endocrine system in every body system, right? We have interactions between the nervous, immune, and endocrine systems are found in all tissues. So these are tissue-based conditions. And then we have sort of the communication between the nervous, immune, and endocrine systems using a shared set of signaling molecules. And then the other piece that you have is this extracellular matrix connective tissue component that provides the physical substrate for these interactions. So I hope at this point you can quickly see why we can't separate out these processes, right? And so you start to see neurologic dysregulation, immunologic dysregulation, and this component of the extracellular matrix playing a role for these patients. And then I show this in every talk I give. This is the autonomic nervous system. And the point that I want to make here is it innervates every part of our body, every organ system. And it basically controls everything we don't think about until something goes wrong, and it's literally all we can think about, right? So all the things we took for granted that we could do, we no longer can do. The other thing that I want to point out is that, we talk about POTS. That's one of the conditions that we see. That's sort of like a single measurement of what the autonomic nervous system is doing. But we know in those individuals, they have autonomic dysregulation and lots of other components that the autonomic nervous system is controlling. The autonomic nervous system also controls immune function. So it does it at the tissue level, but it also does it at the bone marrow level. So in chronic autonomic disorders, you can actually start to see bone marrow suppression, right? So kind of like anemia of chronic disease, these types of things you can start manifesting. You also can have like leukopenia and neutropenia arise in these conditions. And so the autonomic nervous system is interacting with the endocrine system. And again, the extracellular matrix is that substrate by which this is happening. And then if we look at the gastrointestinal tract, we have the gastrointestinal tract being innervated by what we, like in training, all I learned about was the enteric nervous system. It wasn't actually until I got out into practice that I actually even learned the term autonomic nervous system. And so the enteric nervous system is actually just the intrinsic component of the autonomic nervous system within the gastrointestinal tract. And so the gastrointestinal system is controlled by both extrinsic and intrinsic autonomic nervous system functions. And you can actually show in individuals who have autonomic nervous system disorders that are described in other domains, you can have gastrointestinal dysfunction kind of in the same sort of like nerve roots distributed. So it's really, these are systemic diseases. The other thing that I want to point out is that it's not only the vagus nerve that innervates the gastrointestinal system. So oftentimes the vagus nerve gets, I think, too much credit, right? It's a lot more complex. We have both parasympathetic and sympathetic control over the gastrointestinal tract. And then if we look, kind of even closer down, so now we're sort of at the epithelial layer. We've got the lumen, which is truly the outside environment inside our body. And then we have the epithelial layer. But what I want you to appreciate here is that the gastrointestinal tract is truly the largest interface between the nervous and the immune system. And the other thing that's interesting is the gastrointestinal mucosal immune system is actually functionally separate from the systemic immune system. And the reason is because it has to allow tolerance, right? So it's there surveilling what's happening in the outside world, but it can't overreact to that, right? Because you do have a lot of barrier breaks, and it kind of has to be able to modulate itself, that it doesn't go absolutely wild every time that it senses a foreign invader. But the point that I want to make here is that you can see that you have intrinsic and extrinsic nerve fibers innervating individual cells, the epithelial barrier. These are really complex processes that are occurring. And these are tissue-based interactions. And so our blood tests are inadequate for kind of figuring out what's going on. So a lot of times, our patients' labs look wildly normal, but it's probably because they're not adequate proxies for what we're looking at. And then I'm just going to briefly mention sort of like endocrine regulation, right? So hormones produced in the intestine can have both local and systemic effects. Enteroendocrine cells are modulated by efferent neurons, particularly the autonomic nervous system. You have neuropods, so these are these specialized enteroendocrine cells that are directly synapsing with our nervous system. And they're sensing like luminal content, so what's going on in the outside environment within the lumen, and kind of sending that back to peripheral and central nervous system. And then we also have intestinal hormones, and really this is kind of interesting. So for some time now, we've had a GLP-2 agonist that we can use, and we use that for short bowel syndrome. So typically in individuals who have had resection of their small intestine and have insufficiency in that point. And that hormone can actually help to kind of like regrow the intestine. But the other thing that it does is it actually improves gastrointestinal barrier function. We can use it for other indications, actually. And then now we also have GLP-1 and GIP agonists that were originally developed for diabetes and then obesity, and now we're recognizing their broader benefit as sort of anti-inflammatory agents. So now we actually have 3 exogenous hormones that we can supplement back to the gastrointestinal system if it is dysfunctioning. So we actually have more tools now. And then we've also kind of like, throughout the last few years, had this advance in understanding that it's not only neurons that use neurotransmitters, and it's absolutely not only immune cells that are using cytokines and chemokines as signaling molecules. And it's not only endocrine cells that are actually making hormones, right? So now we have this integrated communication system where you have cells of the nervous, immune, and endocrine systems using these shared signaling molecules. So we can't separate out these systems, even though we've separated out our medical specialties and sometimes act like they don't interact. We have to be cognizant of the fact that they are interacting. We have to kind of think about this in a little bit different way. And then kind of come back again to the extracellular matrix. This is a highly regulated system, and extracellular matrix is actually really important for modulating immune function. And so you have migration and signaling patterns that are determined by basically the composition of the extracellular matrix. And so if you kind of have thin matrix fibers, you have easy cellular migration into tissue. But if you kind of have cross-linked matrix, your immune cells aren't going to get there. But you also have certain cells that can intentionally modify this extracellular matrix. And they have to do that for like wound healing and repair, totally normal process, but it actually can go awry. And so you can end up with sort of too much tissue remodeling at the extracellular matrix. And there's a really interesting phenotype that I see in my patients is that as they get sicker, they actually have more joint subluxations, they have weaker tissues and things like that. And that's very likely because they're having dysregulated extracellular matrix kind of remodeling occur. And then we also have components of the barrier function, which actually are considered part of the extracellular matrix. And so it's kind of like the epithelial layer to begin with, but then sort of like the mucin and things like this. All of this is regulated by this neuroimmune axis. And then just to throw one more thing that I'm not going to focus on, but this is really a complex system because the gastrointestinal tract really is the largest interface of the mucosal surface with the outside world, right? And so there's a lot that has to happen here. And our microbes are not just sort of like bystanders, right? They're secreting molecules, they get into our bloodstream and can have impacts even centrally, right? They're also activating these special enteroendocrine cells, these neuropods, and giving them information about the environment. And then those neuropods are communicating with our peripheral and central nervous system as well. And then you have them also interacting with other types of endocrine cells, producing hormones that have both local and systemic effects. And then you have the microbes also influencing our immune system and inflammatory processes that then again is feeding back to the neuroimmune axis. And then the other point that I just want to briefly make is that our gastrointestinal microbiota, we actually, as we sort of grow, we create tolerance to those microbes that are interacting with our immune system. And when we have major shifts in our microbial communities, particularly in our small intestine, this can be very immune activating because we don't actually have tolerance for those organisms. And so we have to think, like about when we use things like antibiotics and things like that, kind of the long-term consequences on this neuroimmune axis that can happen. And so if we just kind of come back to, again, this sort of like, bigger view of this neuroimmune axis, the point I want to make is that these are predominantly tissue-based disorders. A lot of our tests are really, really imperfect. And you can have a significant amount of dysfunction within this system without having like mucosal ulcerations that we see in the other types of inflammatory bowel disorders like Crohn's disease or ulcerative colitis. And I think this is one of the reasons is that we have a lot of symptomatic dysfunction within the gastrointestinal system, but we don't have overt ulcerations. And so we kind of dismiss what's actually happening. But again, there's a lot of details that we're missing. And so, are they really invisible, or are our tests just not great? And I would argue that our tests are just not great, right? And so we really have to recognize that you can have this dysfunction without having sort of like overt kind of ulcerations and those types of things, because there can be changes in neuronal signaling, immune signaling, endocrine signaling, and extracellular matrix that we're not picking up on our current testing. The other thing I just want to highlight again is many patients enter the space after a significant immune activating event. And so they kind of like set in motion this sort of like tissue-based immune dysregulation. And it's not always infection, right? So it can be infection, it actually could be surgery, it could be a traumatic event like a concussion, it actually can be a psychological stressor or even an environmental exposure. And I don't like to separate out these conditions as post-infectious or post-concussive or anything like that, because I see the same phenotype manifest regardless of what the immune activating event was. And I'm going to show you some examples of that. But before I do that, this is sort of a list, and I tried to make this like, how does my brain sort of like focus on these types of things? And so this is sort of like an example of what I think are some of the neuroimmune axis disorders that we're seeing. And you can see a lot of conditions up there with a lot of different names. And so these are complex multi-system conditions. They usually have very few biomarkers or none. A lot of them are clinical diagnoses. The other thing that I think is important to point out is that many of our patients that fall into this space have many more than one of these diagnoses. And this is what really started me thinking about, like, maybe this isn't the right diagnosis. Like, maybe we should back up and see what are the common phenotypes across these patient populations and what are they more similar to rather than dissimilar to. And the theme that started to emerge over time was that there's this neurologic dysregulation, immunologic dysregulation, and then this role of the extracellular matrix. And then kind of within that, there's these cohorts that form. And so I can see cohorts that have really significant metabolic dysregulation on top of that. So like HPA axis dysfunction. These are the people who consume very few calories, but just look very, very obese, right? Like there's some other sort of like inflammatory process happening here. We also have a cohort with this really prominent pain phenotype. And this is sort of like all the types of pain, right? And you just don't know what the driver is, but pain is their predominant bothering symptom. And then you also see like a fatiguing phenotype. And so we often describe this as ME/CFS. But when we look at those patient populations, they also have neurologic dysregulation, immunologic dysregulation, and kind of this extracellular matrix phenotype. And so what I'm trying to do is sort of see the similarities so we stop wasting time kind of studying these individually named conditions and look at the bigger picture. I think we'll make more progress. And so I'm just going to give you a couple of examples of clinical context of where I think the neuroimmune axis kind of plays a role. And so this is in the setting of infection, right? So this is the epithelial layer, and you have your commensal organisms in blue at the top, and then you have a Citrobacter infection, right? And so during the acute infection, you have disruption of the epithelial barrier. You have both your commensal and your pathogenic organism cross that barrier, activates your immune system. The other thing that happens is that you also have luminal contents that have come across as well, right? And so what happens is you treat the infection, however you end up doing that, typically with antibiotics if it's a bacterial infection. But then what's happened is your immune system's kind of working in the background. So it has had an activating event in the setting of an infection. Your adaptive immune system has recognized sort of these foreign invaders and has gone ahead and made antibodies. So eventually the infection clears, you think you're good to go, you feel much better, and then you're kind of going throughout your life, but something happens, right? And so you start to have symptoms when you're eating certain foods that you had previously tolerated and you don't really understand it. But something really important has happened after that infection. So what you see is that the mast cells now have migrated closer to the terminal nerve fibers there. And now they're actually coated in IgE molecules that recognize those food antigens that came across at the time of the infection. And so you are now having a localized allergic reaction to foods you had previously tolerated now after an infection. And so now you have sort of food-related abdominal pain and other symptomatology that happens after this infection. What's really interesting is you can actually recapitulate this same process with other types of immune activating events. This is in a mouse model, but this is psychological stressor, right? And so what they did was open maze swimming for mice and then also expose them to egg protein. And they end up with the same phenotype. So after the psychological stressor, when they would feed the animal egg protein, they're now having abdominal pain symptoms and things like that. And again, because the same process has happened, is your immune system has developed IgE molecules that now recognize that food antigen. And so, and the mast cells have migrated closer to the terminal nerve fibers. And so this just shows us that you can end up with the same endpoint with different sort of starting points. And then how does this mechanism actually work? And so when you have your sort of mast cells that are activated and degranulating, they're releasing a lot of mediators. Most of the time we talk about like tryptase or histamine, but these are really complex cellular processes with over 100 mediators that are released. And so you have your nociceptive fibers that are there in close proximity to your mast cells, and the mast cells start to degranulate and they're releasing things like serotonin and histamine and those types of things. And that causes those sensory fibers to do two things. The first is it upregulates these transient receptor potential channels. And then it also phosphorylates them. So it basically sensitizes them. So any future stimuli has to be, there's a lower threshold to activate them. So now you've kind of created this sort of like visceral hypersensitivity model. And so we start to see people become more and more sensitive to things. And we kind of, dismiss it or almost blame it on them. Like, oh gosh, they just have this visceral hypersensitivity. But this truly is like a neuroimmune process that has taken place. And then, the last point I'm going to make, again, this is all sort of like within the same kind of like processes, right? Is that, again, you have your mast cell and it's releasing other mediators, this time leukotriene. But when you have co-signaling with release of growth differentiation factor 15 from the epithelial cells, these two co-modulators will travel to the central nervous system and actually tell your brain that in the future you should avoid a certain food, right? And so what it's doing is it's telling you, like, this is a danger signal, we should avoid this. This is not an eating disorder. This is actually an evolutionarily protective mechanism that was helping us stay away from things that are causing bad things to happen for us, right? And so we need to think about that when our patients are telling us, I can't eat that, I can't think about that. This is this process taking place and it's protective. So how do we diagnose neuroimmune axis disorders at this point? I say it's not easy. And we do have a lot of different tools that we can use, right, to kind of get after some of these things, right? And so, and I'm kind of like focusing on this from sort of like a gastroenterology standpoint, but a lot of immune profiling. And actually, and I have history up there, and I really do mean that, right? Because a lot of patients, even though I see all ages, but a lot of patients, like, did have kind of early life history with like either trouble with tolerating formula or couldn't be breastfed or had a lot of allergies. Sometimes those are actually cues. Sometimes they have a lot of infections. Like, we have to be kind of like seeking that information to help us understand what's the level of immune dysregulation, how long has it been present, when did it get worse, those types of things. And then, there's obviously endoscopy we can do. And we do a lot of endoscopy, right? And we take a lot of biopsy samples. But in this space, they're not actually that useful for us, right? And so I really do think we have to move kind of the way that we're doing tissue-based diagnostics along so that we get more useful information for our patients and for ourselves so that we can better select, therapeutic interventions. We also have motility testing and things like that. And then we also have genetics. With the exception of kind of like genetics and some of the immune profiling, I would argue most of our tests we're doing really just confirm what the patient already told us, that something was wrong, but it's not getting after why it's wrong. I'm going to give you a couple of examples of just some testing modalities that we can use. I'm kind of excited about that we have here, which is nice. I'm just going to first just take a little bit of a sidetrack here and just remind you, intestinal barrier function, highly, highly regulated process, and it has to be because it has to intentionally let things through and keep things at bay. But this dysfunction of intestinal barrier function remains invisible if we don't look for it. And so recently at Stanford, we obtained a technology that's going to allow us to measure intestinal barrier dysfunction or function in real time, which is really quite exciting. And so this was developed originally for kind of almost like in vivo histopathology. So people were using it in the lung space and things like that to look at tumors and things like that, hepatobiliary, things like that. But then they realized we could actually use it intraluminally during endoscopy. And so you have a person who has symptoms of eating, kind of done all the food elimination diets, and really to no success, right? And so what we can offer is a test that actually looks at this in real time. And the way this works is during routine endoscopy, we use fluorescein as a contrast agent. And so we can highlight the individual villi within the gastrointestinal tract in real time during endoscopy. And then what we can do is if the intestinal barrier is intact at baseline, so none of that fluorescein is leaking into the lumen, we can add a food antigen and then see if that actually disrupts the intestinal barrier. And so if it does, you can see the fluorescein leaks into the lumen. And so that would be a positive test. And so then when we eliminate that food from a person's diet, they actually start to feel a lot better. And I'll just show you what this looks like. And so you can see the villi are illuminated with the fluorescein. You can see them surrounded by microvilli. And then you can see kind of a thin black line in between all of them that represents the intraluminal space. And then when we have a positive reaction, you can see it start to change. And you can start to see the fluorescein leaking into that space. And so this is allowing us to inform people that you are actually reacting to this food in real time. And it's really been quite fascinating in our patient population. I mean, I have really high rates of corn allergy, and corn's literally in everything. These are things that we can also use to help when we're selecting like tube feeds and things like that if a patient's really struggling with certain things. So there's a lot of utility to this technology, and I'm so excited that we actually have it here. Even in your kind of run-of-the-mill irritable bowel syndrome patient, they're finding that 50 to 85% of these patients may actually be having a reaction like this to certain foods. So these are simple things that we can do to help our patients kind of like eliminate the guesswork of elimination diets. So this is a technology that's not only really important for these really sick patients, but can be used for the broader population. It really helps us partner with our patients to make them feel better. And then the other test that I'm going to talk about is small bowel manometry. And so we have lots of manometry here. I imagine most of you are familiar with like esophageal manometry or anal rectal manometry. But we've recently brought back small bowel manometry and colonic manometry to Stanford's program, which is really exciting because I think a lot of times we neglect kind of what the small intestine's actually up to. Even I would argue it's the most important part of the gastrointestinal tract, the one you can't live without. And so we, do a lot of measuring of gastric emptying and things like that, but kind of forgetting what the small intestine is doing. So this is a catheter with a series of solid state sensors kind of dispersed throughout it. It's placed endoscopically and then left in place when the endoscope is removed. And you can kind of see the plain film there where it's kind of coursing through the end of the stomach and into the small intestine. And then this is sort of like a simplistic readout, but you have at the top the more proximal sensors, and then at the bottom lines are the more distal sensors, and then the x-axis is time. And so what you want to see is coordination of contractions across time. So if you have a propulsive contraction, you want it to go from a proximal sensor to a distal sensor. And you can kind of see that in the last few, where the arrow is, you can kind of see that. So that's a forward propulsive contractile motion. And so for the longest time, this was actually considered the gold standard of motility testing, because it was thought that it could differentiate between neuropathic conditions and myopathic conditions. And people were making clinical decisions based on these manometric findings. And so you can see a neuropathic pattern on the left-hand side. And the reason they say that is the height of the contraction. So the squeeze against the catheter appears quite robust, but it's happening simultaneously. So it's not really a propulsive contractile pattern. Whereas the middle panel, you can see that the height of the, or the strength of the contractions based on the height of the spikes is much lower, but it appears propulsive, at least in the last 3 channels, right? You can see them progressing there. And so that they would call a myopathic pattern. But when someone actually finally went back and actually did full thickness biopsies of the small intestine in these individuals and compared the manometric patterns, what they found was that what we were clearly calling a neuropathic pattern was that it was a lymphocytic neuromyositis. And then in the myopathic pattern, this was intestinal neuropathy, right? So again, the test showed us something was wrong, but not why it was wrong. And now we're getting more information as we go back and get a tissue-based diagnosis. And then I just threw the third panel up there because it's kind of interesting. This is sort of inclusive pattern. This is just a lot of activity within the intestine. It's not really going anywhere. It's not propulsive, but it's probably causing a lot of problems. And when they did the histopathology of this, they found mast cell infiltrates within the muscular layers. So, I mean, these are really fascinating findings using this type of technology. And we have the ability to endoscopically do full thickness biopsies and start to look into the deeper tissue so we can start to get more information than just sort of mucosal biopsies that we typically take during endoscopy. So, you know, I kind of want to switch gears as we sort of kind of wrap up is how do we improve diagnostics and outcomes for these complex patients? And I really think that we have to do a personalized precision medicine program. And as part of that, we really have to start leveraging genomics, which I've done in my clinic. We have to start kind of like bringing on some of these higher level technologies, utilizing multiomics and immune system profiling and really improve tissue diagnostics. And so that's sort of my proposal of like, how do we do this at Stanford? We have, the world leading experts in spatial biology here who have developed a lot of tissue-based technologies that we can use to get a lot more information out of the tissue samples that we're getting from our patients. And then again, genetics, genomics, and kind of immune profiling. And so this is, I'm not going to go into detail about this, but some of these technologies were developed here. And so this is giving us better spatial resolution within tissue. And so now we can stain a lot more proteins in a single tissue slice and get a lot more information. So we can start to look at these tissues in more detail and start to make better assessments of what's actually happening at the tissue level that hopefully will feed back to clinical decision making. And we can do it either using sort of like a barcoded fluorescent technology, or we can use mass spec technology. But either way, the technology exists. So it's really just that sort of limitation of application to sort of a clinical space to kind of move these fields forward. And then genetics and genomics, I'm actually using this a lot, and I've been incredibly impressed about how this has actually helped me with my patients. I'm going to just focus on one thing, which is the inborn errors of immunity, right? And so again, there's over 500 described every year they go up. But one of the things that I want to point out to everybody here is 50% of these diagnoses are actually made in adulthood, so after the age of 25. And typically people have suffered for over 16 years. And so just in the last few weeks, I've made numerous diagnoses that have allowed me to select immune modulator therapy based on this testing. So we can't be ruling this out. We have to be using the technology. Genetics is here. We have to be applying it in our clinics. We have to be curious about it. The other thing that I'm going to point out is, even if someone has an inborn error of immunity, we also see in these patients that they have a lot of other immune regulation because the immune system is a network, right? So if someone has an autoinflammatory condition, they're very likely to also have an immunodeficiency, autoimmunity, some complement dysregulation as well. I mean, so there's a lot going on. So we're not one and done, but if we've gotten to the root cause, we can start to layer on therapies, much like they've done in the oncology space, and really start to make a significant impact in these patients' clinical outcomes. And then how do we do this, right? So there's lots of ways. Right now I'm using genetics because that's what I have available to me. But we can really make an immunomics kind of profile where we're doing deep immune profiling, looking at individual cells and not just from the blood, ideally from the tissue, because these are tissue-based processes. We're doing better analysis of cytokines and chemokines, and again, from the tissues, not the blood, because we're just not getting a lot of good signal there. We can look at B and T cell repertoires. We can look at autoantibody detection, which is really exciting, and then again, the genetics. So how do I treat these conditions? Again, like, it's a lot of evaluation, and then we make kind of like a lot of individualized selections for therapeutic interventions. And so I use a lot of drug repurposing. There's a ton of immune modulators on the market, and I'm able to use this in this patient population and really make a significant impact in overall clinical symptomatology, but it takes time. And so mast cell-directed therapies, just because we talked about mast cells, there's just a couple points that I think are important, especially for when we're on the wards. First line, we want to identify triggers and remove them from the environment. A lot of times the patients have done this and they're telling you, I can't be near that. They sound really like picky and finicky, but they really have shrunk their world to the things that they can tolerate. The second line intervention is medicines, and they seem really simple because a lot of them are over the counter. Please don't stop them when they come into the hospital. These are actually really important parts of their clinical care program. And so we don't want to disrupt that because everything already gets worse because they're stressed being in the hospital. And then they're taking away some of these sort of like basic medications. And then we have sort of like layers of how we kind of add these on. What's been really interesting, there's been a lot of drug development in mast cell targeted therapies. Unfortunately, they haven't done really well in trials. And it may be because mast cells, while really part of kind of this inflammatory cascade, are actually also necessary for turning it off. And so we're not seeing the outcomes that we expected. So there's more to be determined about sort of how we're going to modulate mast cells beyond the therapies we're currently using. I'm going to briefly talk about Yao syndrome. And the reason is because it's not a NOD2-related disorder. Typically, we think about that in Crohn's disease, right? But it's also associated with autoinflammatory conditions that don't have ulcerating gastrointestinal impact. And so it's often associated with like a lot of GI symptoms, kind of like fevers and those types of things, a lot of joint pain. But it's easily diagnosed if we actually look for it in our patient population, and we can use kind of the biologics that are already on the market. Typically, I'm using an IL-1 inhibitor. I've had 3 of these in the last 2 weeks that I've diagnosed. Antibody-driven diseases, right? This is actually really exciting because there's been major advances. So antibody discovery, like pathogenic antibodies discovery, has been actually really hard to do. And so we really only have a few autoimmune diseases that we can actually definitively diagnose. But we actually have drugs that can deplete circulating IgG molecules. You can use them both for treatment of known diseases, known IgG-mediated autoimmune diseases, but also to actually even prove a mechanism in some cases. And so then we have other things that we can move on to cures. So these are these CD19 depleting therapies that we could use to potentially cure a number of autoimmune diseases in the future. And so just in summary, I hope that you can sort of see why we have to talk about what the nervous, immune, and endocrine systems are all doing, because they're using this common language, right? And they're playing a really important role in coordinating communication between various body systems. And so when our patients are telling us they have symptoms affecting every body system, believe them, right? These are systemic processes. Many chronic illnesses are caused by dysfunction of this neuroimmune axis, but it will remain invisible unless we're curious about it clinically and we improve our diagnostic tests. We really do need personalized therapies to more effectively treat these conditions. There's been a number of breakthrough technologies, massive advancements in immune modulation therapy. And right now, our most powerful weapon is drug repurposing for other conditions. And so then just in closing, like even if you don't know what to do with these patients, if you simply recognize them when you see them, you are making them visible. Thank you.
Laura, thank you for an amazing talk. I always learn something new every time you give. I listen to you speak. We're going to take questions from the audience. Or Arrow, are there questions online? So while we're waiting for those to ask questions, Laura, I'll ask the first question. Not all of us are trained neuroimmunologists, geneticists. How do you see somewhere like Stanford, multidisciplinary collaborations, like what's needed for this field to move forward?
Yeah, I think it's a great question, and I think about it all the time. I think the first is recognition, right? That this is a disease space that warrants our attention and our curiosity and our time. And then I think it requires us being open-minded and collaborating, because I certainly don't claim to know everything, right? And I want to partner with people who are domain experts elsewhere. And I think what we have to do is kind of build these people, build this group of people initially that are really interested in this disease space. And I think that's where we've seen the most progress in other spaces that are sort of emerging, is that you kind of have like-minded individuals who are willing to kind of like work through the hard parts and kind of become the referral places for these patients. And so it starts by you recognizing the patient and kind of referring them, hopefully, to like a program that we're building. And then we will apply kind of like leading technologies and our expertise and iterate and hopefully improve outcomes and things like that. And so over time, we all get better at recognizing and treating these conditions.
Dr. Ash. Hi, Steve Ash. I'm a primary care doctor. I'm really interested in informatics particularly. And this seems like one of those conditions where observational data can really tell us a lot. We have this treasure trove of data of various things that have been tried in a condition that, let's face it, is probably not going to get a huge number of randomized controlled trials. Can you think of good candidates that we could interrogate the medical record to see if there's some hidden gem of a treatment that we could apply to patients like this?
You know, I think it's a great question. And I would say kind of like yes and no. And the reason I would say sort of no first is I don't think much has actually, especially for the sicker patients, really been tried all that much, right? Like the main interventions that we see are really like IVIG and things like that. And the outcomes data there has not been super impressive. And I think we're really kind of at the precipice of switching over and using different types of kind of like immune modulator therapy. So I think the data is coming, like I think we're building that. But I think that there is the power of kind of recognizing these patients earlier, right? Like I think there's signals in their medical record where they start to kind of accumulate diagnoses and sort of have higher touch points of care, where maybe if we recognize them earlier and kind of got them into like a little bit more kind of like wraparound care, we could maybe prevent the progression of clinical decline that we see across time for patients.
It looks like you have two other people who want to ask you questions, but a very quick follow-up. So an AI troller through the medical record looking for people who are undiagnosed, but also I was thinking, for example, the GLP inhibitors. People are trying them. They're trying them for other things. Maybe we could find out that they were somehow useful in this condition. I can imagine other things like that.
Absolutely.
And thank you for your answer.
Thank you. Thank you so much, Dr. Pace. My name is Alice Sorenska. I'm a second-year medical student. This really had me thinking about kind of eating disorders not otherwise specified that maybe formerly weren't even as a part of the diagnostic statistical manual, like ARFID, which presents as an eating disorder. Patients have extreme sensitivity, which leads to aversion of a lot of different kinds of food. It can be textural, but I'm wondering, some of these more invasive diagnostic procedures like small bowel manometry, where would you delineate the threshold for when a patient, it would be a good idea to check them out if they have kind of a constellation of similar but maybe unrelated symptoms?
Well, I think it's a fantastic question. And I feel like most disorders of eating are not necessarily eating disorders in a lot of these patients. And there is actually data in animal models that shows that if you have an immune reaction to a certain event, you actually have central memory of that event. And so if you had that related to food, right, you can actually have such severe kind of like recapitulation of that peripheral immune response, even just thinking about the food, seeing the food, and smelling the food, right? And so this doesn't mean that this is an eating disorder. This is really sort of like a neuroimmune process that has taken place. And so I do think we need to start exploring more in these individuals. Are they actually having maybe these food allergies that we could actually help them select foods that are truly safe for them to eat, and then create that safety around it and kind of retrain central processes that like, no, you are actually okay here. Like it's going to be a multidisciplinary approach, but I do think we have to start thinking about these other conditions in those patients. Is a great question.
Peter Kale, I was impressed with the confocal laser endoscopy for mucosal testing of allergies. Your slide also showed pinprick skin testing on the left. Is there any correlation between the mucosal and the skin test?
It's a great question. There isn't. And it's really kind of interesting. So especially in patients who have like mast cell disorders at baseline, you'll sometimes either hear that it's like all negative or pan positive. So it's not actually helping us select foods. There just really doesn't seem to be correlation. This seems to be a local reaction that this particular confocal laser endomicroscopy is picking up. And so the skin prick test is used more, I think, for just indicating whether there's kind of like immune dysregulation per se, but not helping us select foods appropriately. And it's the same with like even the IgE testing. It's not a good corollary.
Hi, I'm Angela Rogers. I'm mostly an ICU doctor, and then I have this tiny pulmonary practice. And even in my tiny pulmonary practice, I can think of 3 or 4 patients like this. I think that's probably true of any of us that see outpatients where they fit into this syndrome somewhat and, you know, kind of play an outsized role in what's on your mind because you can't really, you know, you say good news, your lungs seem fine. I hear you that you're miserable. And so I guess I'm wondering, who are the people that you want referred to your practice? Is it really about, you know, because I'll be honest, I don't even know what their GI symptoms are because it's like they have a lot of symptoms and it's not my specialty. So is there something that makes you think, aha, this is the one for us? Or is it more the syndrome and a lot of this GI disease is undiagnosed and we should kind of send everyone your way? What's your wish?
I wish I had the bandwidth to take everybody, but I don't. And so I really have started to focus on kind of the more severe phenotype where they have intestinal insufficiency and failure. But I have amazing colleagues within the GI division. Someone is standing right behind you. Like we have a big group and we're doing sort of like a lot of areas of specialty. But I think it's really even just recognizing that they have these interrelated conditions that we need to sort of start to integrate that into how we even individually for our specialties make selections about what to do next.
I'll add to say, taking Dr. Ash's and Dr. Rogers' questions and putting it together where we can have AI then help say, these are the patients that are best looked at in this neuroimmune axis disorders. And I can say after having done this for almost 20 years now, that you get a flavor when you see the patients, and there's not necessarily like a checkbox. It's really like, oh yes, they've checked all the boxes, and those are the ones that you refer on. But I think it's important to be able to identify these patients earlier, because I think there is sort of thinking about rheumatology, sort of if you intervene early on, you can actually disease modify as opposed to treat. So with RA, we've been disease modifying when you treat early before the joint destruction. And what we're seeing in some of these patients is that these mast cells that Dr. Pace just described, it's next to the enteric nervous system. So if you have chronic ongoing inflammation, you can actually get denervation. So I think the key is if we can identify patients earlier and get into immunomodulation and sort of disease modifying instead of symptom treatment.
Yeah, there's actually a number of questions. I'll try to get to maybe 1 or 2 here, but Dr. Razavi asks, how many antigens can you test for in the small bowel endoscopy study?
Oh, that's a great question. So during the initial endoscopy, we can do up to 5 if there's none positive. But then you kind of like reach the limit of fluorescein during that one session. But we're not limited to one session. So they can come back later and do multiple different tests. And I see as we expand the program, we can start to look at not just food antigens, but we can start to look at preservatives, emulsifiers, those types of things, and really help people understand what they need to be removing from their diet very intentionally.
And I get another question here. What are your thoughts on radiation therapy-induced gastrointestinal dysfunction and its potential as an iatrogenic neuroimmune axis disorder?
Well, I mean, it's a really good question. I mean, I think that you're definitely having a nerve injury. You're definitely having some sort of immune changes. And I think it's entirely possible that you see like long-term complications from that. We definitely know from like the chemotherapy side of things that people can enter this space after chemotherapy and things like that, again, because you have sort of like dysregulation of all those systems.
I might do one more on, there's so many here, these are great questions, but Dr. Nishatia asks about the impact on the psyche on neuroimmune access, the connection between psychologically and the disease itself. I'm not sure if they're asking directly about like psychiatric issues or just, I'm also wondering as well, just the emotional impact as well, the psychiatric impact these patients deal with.
I'm going to try to answer that question, I think, in like a couple of parts, right? So one of the reasons I sort of frame my talk about seeing the invisible is that we actually cause a lot of trauma by not believing our patients, right? And I think we dismiss and minimize because we don't have sort of like these overt, like wildly abnormal tests. We don't have ulcerated, small intestines or colons and things like that. We kind of tell them their pain is out of proportion to like what we would expect, but this is their experience, right? And these are tissue-based conditions. That causes a lot of trauma, causes a lot of distrust. And then they kind of go into that sort of kind of mode where they're kind of like always sort of kind of having to advocate and they don't feel safe, right? But then I do want to say that there definitely is central encoding of immune memory, right? And so we have those pieces playing a role, and that can manifest as sort of like hypervigilance and things like that. But that's because they're really feeling these things. And then the other thing that I'm going to say is that there is a patient population that has a neuropsychiatric phenotype. So like we talked about sort of like metabolic and pain and fatigue, but there's definitely individuals who have a really predominant neuropsychiatric overlay. And sometimes we call it pandas and pans. But I mean, there's a lot of different components to this. And we definitely see this. And this is probably, in my mind, a component of neuroimmune axis dysregulation.
Dr. Nguyen, thank you for hosting, and Dr. Pace, thank you for that amazing presentation and time.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.